is a very safe and effective treatment option. Though I have mentioned the side effects, the percentage that we come across is very, very less and is a very, very good effective tool for controlling myopia. Thank you.
Thank you, Dr. Prachi. I now invite Dr. POOJA. Can you come to this one, please? Yeah. Dr. POOJA GHALLA Gogri. She's going to speak to us about the non-responders. What do we do when atropine fails?
Good morning, everyone. So at the outset, I would like to thank Dr. Ashwin to give me this opportunity. And when we are discussing this topic about, we've heard about atropine working very well, but what do we do when it fails? And myopia progression is a real concern in the current day and age. So the reason we're even discussing this is because all the current studies have shown that there is about a 12 to 15% children who are either slow responders or non-responders to atropine. So we said that if myopia progression is not halted by about 50% using either low-dose atropine or atropine, we will either label them slow responders or non-responders. I'll take the talk through causes, alternative therapies, additive therapies, the experience that we have at our clinic, and newer therapies that we can look forward to. So coming to the causes, we need to start investigating and definitely begin with the history and examination. And why history? Because we do know that children who are younger and those who have a higher myopia at onset and children who have parents with high myopia or myopia are known to be progressors, faster progressors, and have a higher risk. Lifestyle modifications is essential to know because it is the safest strategy to still control myopia progression. We cannot ignore it. We must spend some time to actually advise it properly so that the parents and the child know that it's significant. If they're not following it, we must keep reinforcing it at every visit. Go to the history of the method of the drop installation for the atropine drop. Ask the parents, how is the drop instilled? Sometimes we may see that one pupil is better dilated than the other if the child is on a 1% atropine drop. And if one drop is not working well in one eye, either because the child decides to turn his face and the drop is washed out, or the child cried or had excessive tearing, there could be a failure to the drop installation, which is not actually a drug failure. So if that is probably the cause, we need to make sure that we teach them how the drop needs to be instilled. This can be done by telling them to lie down straight, use a tissue paper, instill one eye before the other eye, keeping some time in the middle, dab the excess drop out. One day you can start with right eye first, left eye second. The next night you can use left eye first, right eye second. If we know that the drop is instilled correctly, and there is myopia progression, then we may consider this case as a case of drug failure. Also, it's important to know, why do we have to look for the next line of management? Is it an allergy to the drop? Is it some contraindication or a complication? Coming to the examination, often binocular vision anomalies are also responsible for progression of myopia. So like Dr. Siddharth discussed about the causes of myopia progression in the pathogenesis being accommodative lag, or those patients who have a near esophoria, we need to look for those and treat it accordingly. In patients who have ROP or syndromic babies, we must ensure that these are not actually progressive myopes which we can treat, but make sure that we are sending them across for their genetic evaluation or the pediatrician for systemic evaluation. Now, what is an alternative therapy if atropine fails? So I'm going to basically discuss ortho-K lenses. So what are ortho-K lenses? These are lenses which work by flattening the central portion of the cornea and steepening the mid-peripheral portion of the cornea. They are worn overnight for about constantly minimum of 8 hours, and they best benefit patients with low to moderate myopia. They are dispensed by the optometrist based on refraction and topography of the cornea. The follow-up is extremely essential for patients on ortho-K lenses. We must make sure that we see them on day 1, day 3, day 7, 1 month, 3 months, and 6 months post ortho-K prescription. On follow-up, what do we want to see? This is a pattern that we see, which is called bull's-eye staining. We're seeing that the fluorescein is taking up stain in the areas of the perilimbal area and in the mid-peripheral section, which is getting edematous. And the topography on follow-up will show us that there is a central flattening and a mid-peripheral steepening. This shows that the ortho-K lens is affecting the corneal shaping. Despite knowing that this is a technology which works well, it is not extremely commonly used, and it has to be used with certain caution. And why is that? Because of the adverse effects. The most common adverse effects that are reported include tear film anomalies and disturbances in children. However, the good news is that it settles within 1 month of discontinuing the contact lenses. But we have some vision-threatening complications, which include microbial keratitis, and which is why a very good counseling, patient selection would be necessary, making sure that we follow up regularly, and it is reinforced that we must see the child if there is any hint of redness, watering, pain, etc., and there's no time lost for the follow-up. So microbial keratitis is known to occur 20 times higher risk than those who use conventional daytime soft contact lenses. There is an American Academy report on using ortho-K lenses, and what they said is that the axial length elongation is reduced by about 50% over a 2-year study period. That means it is effective in controlling axial length elongation. It works better for younger children at about 6 to 8 years of age, and those children who have larger than average pupil size have better effect. Rebound effect can also occur after discontinuation or change to an alternative refractive therapy. So rebound must be still kept in mind when we are following up the child. And safety remains a concern because of the potentially blinding complications of microbial keratitis. So if not ortho-K lenses, what are the additive therapies that we can look for? Additive therapies is what we look at synergy. So we want to use methods that are going to work on different pathways that cause myopia progression. So if we look at all the pathogenesis that has been discussed, we can broadly classify them as pathway 1, which affects the scleral strengthening. It reduces the elasticity, it improves the choroidal perfusion, or it increases the choroidal thickness. So what works on this is atropine drops, and there is a newer therapy called very low intensity red light therapy. There's a pathway 2, which would cause an increase in dopamine levels, and what causes increase in dopamine levels include atropine drops and outdoor activity in daylight. And pathway 3 is using the strategy of using the peripheral defocus reducing strategies. Now this peripheral defocus, hyperopic defocus which is occurs due to multiple causes, including our binocular vision anomalies. So everything is treated with ortho-K or DIMS lenses or peripheral defocus lenses or multifocal contact lenses that are available. So there have been a recent study, which is a 2-year-old randomized clinical trial, which looks at combined therapy for low dose atropine. So this is 0.01% atropine along with ortho-K lenses. So what they did is they looked at 2 groups, one group which was using monotherapy only ortho-K, and the other group which was added on atropine low dose. And it showed that there was an axial length elongation which was reduced in the combined therapy versus the monotherapy group. However, it is more effective in patients with lower myopia, that is up to 3 diopters, than moderate myopia. So I'm not very sure exactly how this is going to work, but when we are looking for alternative therapies, we will have to look to alter and add when we do not have any other resource to look for. There is another study which is looking at the combination of low-dose atropine, which is 0.01%, along with a peripheral defocus soft contact lens. So this was only a case series of 3 children, and these 3 children were progressing at the rate of about 1.12 diopters for the last 3 years. And these children were then started on this combined therapy using daily disposable MySight lenses, which are newer lenses. They work on spherical peripheral defocus theory, and progression in these children was, all the 3 children was reduced to 0.25 diopters in the subsequent year. That means the peripheral defocus multifocal contact lenses along with low dose atropine also worked. So for those children in whom we cannot use a 1% atropine because there is an allergy or they are not tolerating it, we can consider shifting or stepping down to a low dose atropine and adding another therapy, which include either ortho-K and or peripheral defocus contact lenses.
Dr. POOJA, you have about 2 minutes.
Sure. So I would like to go through our experience at the clinic. This was at Jyotirmay Eye Clinic, and I would like to thank Dr. Mihir Kothari for all these patients. These are all his patients that I'm talking about. There were 140 children of progressive myopia who were on 1% atropine with progressive addition lenses that were seen from 2015. We've analyzed the data up to May 22. Out of 140, only 12 children were progressing on 1% atropine. That is about 8% children were failing to be controlled well. The average age was 13.5 years. That means these children were older. 6 out of these 12 children showed no progression after changing the frequency or dose of the atropine used. So 50% of this 8% did well by altering this 1% dose. So what was done? For 2 children, the dose was shifted from HS 1% atropine to morning dose, and they stopped progressing. For other 2 children, LDA was added, or a low dose of 0.01% was added in the morning along with bedtime 1% atropine. And 2 children used atropine 1% twice in a day, and they've stalled progression. There are 4 children whose follow-up is awaited. 1 child showed failure because the child had photophobia, so we had to step down to LD, and we've started the child on DIMS as well. And 1 child had to discontinue atropine because of allergy. Looking at newer therapies, there is a newer study which is a multi-center randomized controlled trial to look at low-level red light therapy, wherein 264 children were treated with therapy using red light of a specific specific wavelength, that is 650 nanometer, 1600 lux, and they were used to expose this light on the screen at home under parental supervision for 3 minutes a day, twice a day, with a minimum interval of 4 years, 5 days a week. Now there was an interventional group which used single vision glasses and red light therapy, and the other one used only the single vision glasses. It shows some proof that there is some progression that is limited, however, and no severe adverse effects are reported, but we are not sure of how well we should take this study in the light of adverse effects that may be showing up later with red light. Other therapies to look out are going to be altering the illumination at home, VLRL, role of vitamin D3, and caffeine supplements in the future. So should I just take this or? Yeah, okay. So in summary, first we need to look for whether there is a drug failure or a drop failure. We need to reinforce on lifestyle changes. It is very critical that we tell the patients at every visit, because the children need to hear it from their doctor. The parents are always bantering them about their lifestyle changes. Binocular vision assessment should be looked for in patients who are having accommodative lag. Until more evidence is available, we can use the current knowledge of the pathways that cause myopia progression to add additive therapies. Stepping up the dose of 1% atropine to multiple times a day also helped in our patients. And even if progression is not halted completely, they may still be slower progressors than they are going to be without the atropine altogether. So do continue atropine drops and very gradually keep tapering it to make sure that we do not look at the rebound effects adversely. Thank you so much. I would like to acknowledge everyone who helped me in the presentation, and thank you.
Thank you, Dr. POOJA. So this actually is all the topics we have on myopia. We also have a keynote talk just now. We'll still have some time of about 5 to 7 minutes in the end to take questions on myopia, so please hang around.